Hello and welcome to the HSJ Health Check Podcast, where each week we discuss the very latest coronavirus news and analysis of the impact the pandemic is having on all corners of the NHS. I'm Senior Correspondent Annabelle Collins, and this week I'm joined by Deputy Editor Dave West, Bureau Chief Ben Clover, and Senior Correspondent Rebecca Thomas. So today we saw the normal data released by the NHS on performance. This is kind of routine data that is published. And so some of our team have been kind of getting stuck into it, as it's given quite an interesting insight into what was going on in April. So we're slightly looking back a little bit for this, but I was just hoping that, Ben, you might be able to give us some of the kind of interesting headlines from some of this data.
Well, yeah, it's quite startling, some of it. I mean, it's not unexpected, but still pretty marked. So the data is staggered. So we've got last month's data, we've got April's data for A&E performance, and what's really startling, really, is just that the attendances that for April were 900,000 at A&Es. Across England, right? That's compared to 2.1 million last April, right? So that's for a bit of context. Not only is that the lowest ever, it's way lower than the record. Like the record lowest was actually March, which is at 1.5 million. So the fall off just from March to April is really profound. And for context, over the past decade or so, the lowest it's ever been before was a sort of fluke month in February 2011. So this is a really unprecedented decline in attendances. A couple of things to say on top of that. First off is that the service has not been meeting the main performance target for seeing people within 4 hours for quite some time. So the target was 95%, but 95% of attendances should be seen, treated, or in some other way dealt with within 4 hours. Like in April 2019, that figure was at about 90%, so way below. We're only at, sorry, that was 85%. This year, this April, we're only at 90.4. So we're still not hitting the target. It's an improvement of about 5 percentage points, but it's still maybe not quite what you'd expect, considering the number of people coming through doors has more than halved. So it's a really significant fall off.
Ben, do you think, because there's been some, when we started to see this effect, there was some people sort of initially kind of started celebrating, I think, and saying, oh, great, at least this is one thing we've learned from coronavirus, is actually how to, that so many people don't actually need to come to A&E, and that there are other digital and primary care and sort of self-care means of dealing with this stuff. But then so pretty rapidly after that, actually everyone started panicking because they realised that there were people who were probably genuinely very ill and needed to have stuff checked out at A&E, so who weren't coming in, and it would, as far as we're aware, that's still the case, I think.
Yeah, it's quite alarming, some of the specialty data, things around stroke and some heart-related things, who you just would expect to see come in, and we saw a lot of the medical specialties saying to people, please come to A&E.
That's the assumption. But if we learn any more over the last couple of 2 or 3 weeks about whether it, how much this is a real a big problem versus,
there's not been releases from of really drilling down into that data from the specialty colleges about things like death rates. I mean, we've seen the excess death rate methodologies, but we haven't unpacked and unpicked and quantified a lot of that yet. I mean, just looking at the data, the A&E data they put out, the fall in, I mean, and this is not a great proxy for severity of attendance, but it does break it down into type 1s, which are, the consultant at A&E, type 2s, which are less severe, and the type 3s, which are your classic urgent care centre, kind of walk-in centre kind of things. And the decline, the decline overall is by more than half, and that's kind of proportional for type 1. But the decline in type 3s is even steeper, kind of about a third of a number of type 3 attendances came through the door. So it does seem like people have been dissuaded from less intense conditions that they've come in with, but it's still that number's still quite small. I mean,
and admissions, so things that the clinicians thought needed to be admitted to hospital are still down by nearly 40%, I think. So, which suggests that less so than attendances, but that there are things that have been serious enough to normally admit people to hospital are not there. But again, we don't know how much of that's because people aren't getting sick or breaking their bones
by not going out as much.
Curious, what was the performance against the 95% target with this big decrease in attendances?
I did say it's kind of it went up year on year by about 5.3 percentage points, but it was still at 90.4%, still some way below the 95% target. I mean, that might be because hospitals were putting a lot of their resource elsewhere. But in most scenarios, you might sort of imagine if you more than halved the input, you might get an increase in performance a little more than we've had here. But that data only came out today, so we've not unpacked it fully.
I guess the hospital people involved, I suppose, would say, well, we have had a massive collapse in activity, but we've had to split the department in half and reallocate all the staff and
absolutely, yeah. No one would say that the hospital system has been unimpacted by the other stuff going on. So we might expect this. Kind of the other really big, although perhaps not the most worrying one, I'll come to that in a second, but the other really stark change has been just in planned procedures. So the reduction that Simon Stevens in mid-March wrote to trusts saying you should be looking to cancel all your non-urgent elective procedures by no later than mid-April. That's seen some really quite staggering, again, I've got to stop saying staggering, but some really significant changes to the numbers. So the NHS has two main performance measures for elective work, and this is a waiting list with about kind of 4.4 million people on it, just for context. It's got two main performance measures. One is the number of patients treated within 18 weeks. One is patients shouldn't really wait more than a year. So this data is for March rather than April. It works 2 months behind, so we don't have the quite as up to date as for A&E. But so just for context, in March 2019, there's 1,154 patients waiting more than a year. In March 2020, that jumped to 3,097. I mean, the number doubled just from February to March this year. So you can see the effect there of trusts just cancelling all of their waiting lists. And we're 6 weeks on of largely cancelled procedures from even this figure. Right, so if you look at the data for people who are waiting 46 weeks or more at the end of March, then you're looking at another 14,000 people who right now have waited more than a year for their procedure, which is again pretty stark.
Rebecca, I don't know if there's been I don't think there's any sort of recent data on mental health activity out today, but is the sense still that activity is well down in mental health services?
So we'll have to wait another month for that. The data so far is just for February and provisionally for March. So if we want to see April, we're going to have to wait a couple months. But so anecdotally, the feedback is routine referrals, routine attendances are way down, so took a nosedive just after the pandemic. Although there have now I'm starting to get reports. I wrote about this last week. Starting to get reports of increased acuity. So small numbers of iller people showing up. So obviously there, and NHS England are warned about this. There could be a windfall of serious need in the next 6 months. We don't know yet, but
yeah.
Rebecca, that was quite a good segue into our next kind of topic of discussion on this podcast, kind of getting a little bit more deeper in kind of the mental health trust, and also kind of care of people with learning disabilities. And you're waiting, as I understand, you're waiting for some data to be published today on that, and it's obviously not out at the time of speaking, but I was just wondering whether you could take us over kind of what has been the basis for thinking that there's a problem in this particular area.
So I don't think there is yet evidence that there is a problem, but there has been a problem with, I think, the lack of oversight for those with learning disabilities, mental health, and autism. We know across these groups, research has proven across these groups, they have worse health outcomes. For example, those with learning disabilities have a higher rate of respiratory problems. Those with severe mental health illness have high rates of obesity, smoking, and we're 2 months into the pandemic now, and data hasn't been looked at on whether this group are disproportionately affected. So I think that's the issue, that it's taken this long for it to be noticed that it needs to be looked into. So yeah, we are expecting the figures today to see which will reveal whether it is a problem. I guess on the inpatient mental health side, it will give us a view of what the outbreaks might have been like, and in terms of whether it has been appropriately or inappropriately contained in inpatient mental health units. There's that, it's wrapped up in, I don't know, you will have seen the news around the inappropriate inclusion of DNRs.
Yes, I was going to ask about that. Yeah.
Yeah, so just after NICE published its critical care guidance using the frailty scale, it's huge controversy, not just for those with learning disability, mental health, or autism. It was across the board, across care homes, that people were going to be discriminated against because of their frailty. And Learning Disability England today, a body that represents providers, have said in April their providers were still reporting to that they were receiving these inappropriate DNRs. So by inappropriate, I mean DNRs that haven't been discussed with the patient, family, or staff looking after them.
So this, do you think this data that you're expecting will kind of give more of an insight on what's actually been happening in this kind of quite underreported kind of sector of the NHS?
Yes, there are huge caveats to the data as well. Obviously, it's not going to tell us the circumstances of these people's deaths. It also depends. It will also likely depend on the clinician or hospital actually recording a person's learning disability, mental health, or autism condition. So people could be missed out if they just simply weren't. If this wasn't recorded, and then most obviously it's not going to include care home or deaths in the community.
Why, Rebecca, there's quite rightly in all sorts of areas been people calling for kind of transparency over who's being affected by coronavirus particularly badly, and we've seen that through Black and Asian and minority ethnic starter data, which does show inequality essentially, and raise lots of questions. Are people sort of asking about mental health and learning disabilities and autism because there's some sort of evidence that there is a big problem there with coronavirus, or are they asking as a kind of precaution to check out that whether or not there's a problem?
Yeah, I would say it's the latter, because I think it's well documented going into this. There was an inequality in looking at the mortality rate particularly for those with learning disabilities. A whole national program was launched because of it, because that group was going unnoticed. So yeah, it's definitely the latter. We don't know if there is a problem yet, or they're disproportionately affected by COVID, but I guess the point is it's important to look at it.
Yeah, in terms of people who are living and when people are living in accommodation, when people are inpatients, then there's an obvious reason why it might be a setting where there could be a high spread if there's if like care homes for older people, if there's a kind of neglect to do enough about it to prevent it.
Definitely.
And this is sort of kind of links to the kind of next thing we were going to talk about around testing. But I was just wondering, Rebecca, whether there's been kind of much insight on testing in mental health trusts or in care homes or anything like that. Has there been much on that?
So testing towards the beginning of the pandemic was a big problem, and I think testing across the board came to mental health trusts a lot later than it did to acute. So testing for patients and staff. A lot of mental health trusts were cohorting patients that were clearly suspected had COVID-19, but couldn't confirm it because the testing wasn't available. So there was a problem. I don't know if there still is a problem with testing.
And kind of more nationally, kind of just moving away now a little bit from mental health and LD, but looking at testing nationally, I'm hoping someone can kind of talk about the story we published a couple of days ago around test data from commercial labs going into a black hole. I don't know, Dave, do you want to make kind of talk about that?
Yeah, I've been a bit involved in that. So there's been a whole backdrop of the backdrop to it is that there's been a load of concerns made, publicly and very pointedly by all sorts of senior figures about the testing regime, about the testing program for coronavirus, and there was an infamous rush to be able to carry out 100,000 tests per day. By government, led by Matt Hancock, by the end of April, which was only met again, as HSJ revealed, by including in the counting the posting out of tests in order to reach that 100,000 figure. And so there was an enormous rush to expand the testing capacity because it's needed, and also because of this very ambitious government target was set. And then we've learned the story that you referred to has come out in the last few days, because we learned that the data about how many tests were being tested positive, large parts of that were not being made available either nationally within the system or at local and regional level, where people in the NHS and in local government are really keen to see how many people in their area or what percentage of staff in this particular trust or hospital are testing positive, because of course that can help gear their response. Where are they going to put their energies and focus, and how much do they need to worry if lots is coming back positive and things like that, or perhaps they need to take a different approach if too many are coming back negative. I don't know, but so the ones which are not being reported on are tests which are taking place in commercially run labs. So tests which are being carried out in NHS run labs, which were kind of the first ones to start on after Public Health England were the first ones to start on coronavirus testing, are available within the NHS and some extent in local government as well, because the NHS kind of has that data. But what was rapidly expanded under a national programme is a series of other labs and processes which are run by a series of private companies. This includes the big centralised Lighthouse labs, and I believe it also includes which are doing staff, particularly started with NHS staff testing and are doing social care staff testing and other key worker staff group testing. That's all being run through these labs, as well as some other processes, I think referred to as satellites, where testing facilities and things are sent out to local organisations to test their staff and so on. So it's the people who are tested, the members of staff or individuals, are getting their result. So it would be obviously even more serious if their results were going missing, and there is a level of concern not about the results going missing, but about the accuracy of some of this stuff, the results. But this is not about that. This is about the data at a mass level or regional or local, across a particular CCG or region or local authority, the data not being available, and at national level, we've been again reliably told that the centre is not getting the information that it was out of this programme of commercial testing as well. That seemed to disappear roughly a couple of week or so ago, and doesn't appear to have come back on, although the Department of Health is stressing that it feels that it has fixed some of the problems that were there, and that they're not directly addressing this issue of the fact that regional data isn't made available, but the Department of Health seems to think it's all in hand.
And the absence of this regional data, why is it so important? So why is it really important to have a really kind of accurate picture of cases kind of in specific regions? Does this help with kind of, I don't know, kind of easing lockdown measures, or just understanding it better?
It will be important. I think at the moment, why is it important for people? A variety of operational reasons, but particularly if you're in charge of a CCG or a local authority for Brent or something, you want to have a clear picture whether the cases which are testing positive are growing or falling, because you will want to respond your kind of health and other services in readiness to do something about that, or another scenario, you are running a particular health service or hospital trust, you want to know how many of your staff are testing positive and how many are not, because it has a big bearing on whether they're going to be working or not. So there's a couple of examples that sort of right now. I think there's a kind of wider symbolism and consequence of this as there are attempts to step up a proper sort of track and test and trace system very rapidly to contain the spread of coronavirus, and there's been a lot of contentiousness about whether that should be run as a central operation or run as a local operation by local authorities and the NHS locally, and the fact that this bit is broken, i.e. a local area can't find out accurately how many positive tests are happening in their patch, or a trust can't find out which members of their staff are testing positive, is being, I think, also seen as a symbol that this bodes very poorly for there being an effective track and trace operation very quickly, because if you can't, to have a sort of a tracing operation in your patch, you need very detailed granular data, very quickly, so you can go and trace the individual and talk to them about who they've contacted and been in contact with, and ask them to stay at home and that sort of stuff.
And that wasn't that one of the five pillars that obviously they
I think this is, we're particularly talking about pillar 2 essentially, but whether it includes bits of other pillars I'm not entirely sure, but pillar 1 was the NHS testing, and the data from that is available, but this is the bulk of the rest basically in pillar 2.
Dave, did that testing, did it include people being tested before they come back in for elective and other cancer care? Because isn't there a directive that patients have to be tested before they can come back into hospital and for any other type of care?
The NHS was asked to move quickly to testing all people who were admitted to hospital, either presumably sort of beforehand for elective care or immediately as they come in for emergency care, in order to with the stated aim of I would think trying to keep sort of clean services and prevent the spread, slow the spread within healthcare services, but also perhaps a little bit just to try and meet those 100,000 and now the 200,000 testing target that's been set. I think they're mainly being carried out in NHS labs, so it probably doesn't hugely affect those, but I'm not 100% sure on that. I think there's a different question about how much the NHS has actually been able to provide that put that testing in place so far, because it's obviously a massive logistical ask as well.
And Dave, just before we close the podcast, I was hoping to just talk about one last thing, which kind of links to kind of what's going on in different regions. But you also reported this week about the virus persisting at a higher rate in the north of England. And yeah, it's just interesting to see this kind of differing experience around the country. And I was just wondering whether you could just kind of give a few of kind of the main points from that story.
Yeah, that story included various bits of data and sort of and views from senior people in the health system in the northwest especially, but also the northeast and Yorkshire. And the new data that was in there was about which we was shared with us was about the rate of hospital admissions for coronavirus, which along with which the deputy chief medical officer highlighted last week actually as a particularly good measure of the prevalence of current spread of coronavirus in an area, because how many tests come back positive is a bit of a difficult measure, because so many more tests, as we just discussed, so many more tests are now being carried out. So you'd expect there to be more positive ones coming back. If it's easier to get tests, you're going to get more positives. But people, from pretty much the beginning of the outbreak, people who were admitted to hospital with it were given a test. So that figure should be reasonably safe, kind of level of how many people are actually coming to hospital and then being judged to need an admission with coronavirus should be reasonably sort of clean measure of things in a way. And essentially it shows that coming down off the peak at the end of March and late March, but more into early April, the peak of hospital admissions, they've come down a long way in all regions compared to that, but they seem to be staying distinctly higher in the northwest. And so that raises one level of concern about the northwest, but also in recent days and weeks, the largest numbers of deaths in hospital from coronavirus are also being recorded particularly in some parts of the northeast, and rapidly rising infection rate data from the tests is showing the fastest rising areas are in the northwest and in the northwest particularly.
Do we have any kind of do we know why this is? Are there kind of any kind of ideas around why we're seeing kind of this rise?
Partly it's because some of those the regions peaked a little bit later, but the admissions in the northwest and some of the other data seems to be staying higher, even once you kind of take account of that. So the northwest hospital admissions only peaked a few days later than London, but the regions had a higher rate of hospital admissions for like well over a week now, so that's not the entire reason. I don't think we know the full reasons, and and it's we're absolutely clear that it's not certain really what's going on at all, like with a lot of this coronavirus discussion. But there is concern, and it's kind of I think it's fair to say that the data has kind of resonated with concerns of people in the health system and public health system in more deprived areas, which there's many more of in northwest, northeast, and Yorkshire. There is some link to various factors of deprivation. For example, the fact that there might be more multi-occupancy households. There might be more people who, for various reasons, it's harder to get information about the risks of coronavirus and information about what you need to do to prevent it. There may be more people with jobs and kind of financial problems, which mean they really need to go to work, or financial status that means they really need to go to work. There are more people with long-term conditions and multiple long-term conditions and kind of clinical frailty and all that, those kind of things.
Do we know about the excess deaths, whether there are higher rates in certain parts of the country? Whether the rates are higher in the northwest? Yeah,
so I should have been clear about that. See, when I was in the piece and when I was referring to that, I was talking about excess deaths really overall compared to coronavirus deaths, because I think excess deaths are the best, generally people seem to think are now the best measure of coronavirus deaths, full stop, coronavirus related deaths. And so in the highest total number of excess deaths so far across the whole outbreak, I think is still in one or two parts of northwest London, highest total on a population basis, I should say, still in one or two parts of northwest London. But as we go each week by week, if you look each week by week through the outbreak, the northwest, parts of the northeast in particular and northwest, are kind of gradually are sort of essentially catching up. So in the most recent couple of weeks, many areas in the northwest and northeast, and one or two in Yorkshire as well, feature kind of much more highly in those numbers. So that's one of the things that's causing the concern.
I don't know whether from talking to people, it's sort of a particular kind of alarm in those regions, considering lockdown has been slightly eased as of yesterday. I don't know.
Yeah, well, Andy Burnham, along with the sort of Scotland and Wales, Andy Burnham, the Greater Manchester Mayor, and Steve Rotherham, the Liverpool Mayor, have basically signalled that kind of concern, that they think it's too early for them, and that they also have asked for sort of better regional measures of spread to be published, which should happen reasonably soon. I thought it's kind of inevitable, but it might lead to regional decisions about where can be unlocked and locked down and things as well.
That seems like a sensible thing to
But I don't know if is anyone, I don't know, maybe Ben with a hospital in the world of hospital chief execs today. I've sort of sensed that the concern is some people in the NHS are a bit concerned about it, but they do. The main sort of mood I've picked up is that, well, we do want to be very cautious about unlocking, but actually generally people seem to feel the pressure is coming down, even in those regions.
I deal mainly with people in London, but generally the sense is, and has been for a couple of weeks, that we now want to start focusing on getting as close to business as usual as possible. And again, some of those stats out today showed just how far away from those from business as usual we got. I mean, and the excess deaths that you mentioned, they're the better measure, because those are going to pick up those people who died because they didn't come to A&E when they were having a stroke or a myocardial thing. So just a little stat from what came out today. Normally the NHS deals with about 40,000 urgent cancer referrals a week. In mid-April, that got down to about 10,000. So I mean, and these are the urgent 2-week cancer referrals for a suspected case, and so people not coming to the GP to be people not having a GP assessment is one thing. People not then being referred on and starting their treatment later is another really worrying thing. I mean, especially when roughly 3% of those people will have cancer. So you could do the maths and figure out how many cancers are out there as of now, like undetected, and where treatment hasn't started. So hospital leaders that I've been dealing with have been very focused on, whilst not wanting to lose the ground that we've made on it, on addressing those other factors.
People are really torn, I think, aren't they? Wanting to get onto all that stuff and not wanting to see, also people who run the hospital naturally don't really want to see it going their staff being, not having something to do, if they can be treating patients instead. So torn between that and a kind of concern about it being really difficult. I think you wrote that headline which said it's harder to start services up again than it was to close them down, and
much more complicated
really and a bit risky as well.
I mean, even down to not just where stuff is done, but how patients get to that particular ward. How it's going to work in the lifts and the corridors.
I was talking to a chief exec kind of earlier in the Midlands, and they were saying they were hoping to start some elective surgery at the end of May. But a big condition was making sure it's safe for patients to actually get in the hospital and get to the right bit of the hospital. I think that is quite logistically tricky.
I mean, that's quite a reality check, isn't it? Because it's end of May, still 2 weeks ago, and parts of the Midlands weren't that massively. And obviously, some parts were heavily affected, but some parts were definitely not among the most affected areas.
Absolutely.
I did.
Well, I think on that note, sorry, Rebecca, did you want to add something?
I was thinking I had an interesting conversation with a trust director who was saying in their planning to return electives, they're heavily thinking about deprived populations and whether they might need to more actively restart electives in those areas, in those populations, which I thought was very interesting. But
No, definitely. A very good final addition. Thank you, Rebecca, and thank you, Dave and Ben, as well. I'm going to draw it to a close this week. And thank you so much for listening. As ever, the HSJ Health Check is available each week on the hsj.co.uk website and across all the main podcast channels. Please do continue to subscribe and share and get in touch if there's anything you'd like us to discuss. Thank you for listening, and we'll see you next time.